Good evening, everyone. Thank you for joining me. I am Dr. Philip McMillan, and I have been probing COVID since 2020, trying to understand all of the pathology, trying to explain the mechanisms of disease presentation, and giving you an insight into the science about what is happening. And today I'm taking on another one of these case reports about sudden cardiac arrest in a young adult, where it gave a diagnostic challenge. This is from the United States. The link to the paper is in the description. And as usual, I'm taking the view that I want to understand why COVID inflammatory changes in the heart, whether or not from infection or from vaccination, were not included in this paper. And the reason I'm pushing this is because I've recognized that if the clinical community doesn't stop just following along with the narrative that, COVID is no big deal and there are no longer term implications, they're doing a disservice to patients. And so this is part of my challenge because this is not what the authors said in the paper. This is my opinion, my analysis, my question. I'll take you through why I've done it. You don't have to agree with me, but here we go. Just a quick mention before I start in the description as well. I'm trying to overcome the fact that somebody's impersonating me on Telegram. So if you are a Telegram user, please look in the description. There is a link to a channel that I've created. My hope is that if I build up enough numbers, that will demonstrate that this is the real me, not somebody else. So please join if you are interested. So let's get to this case and what it was talking about. So here we have a case report from the United States, and it was done in 2025, and it was about sudden cardiac arrest because it's a leading cause of mortality in young individuals. And this has been getting a lot of attention recently as people are talking about the fact that people just seem to be dying. Now, as far as the narrative goes, it is purely in your mind. It is not real. You are just focused on it because you're hearing about it in the news. Well, I would say that from my point of view, I expect these numbers to rise. And it's very similar to if we go back in history, if it was in the late 60s, early 70s, everybody was smoking. I would be saying, I expect to see a rise in cancer. I expect to see significant changes in the prevalence of vascular disease because this is just the science. And so, in the same way, I would say that in the context of what has happened in the pandemic, I expect, based on my scientific extrapolation, to see more and more cases becoming frequently more happening where there is sudden cardiac arrest. And by the end of the presentation, you should be able to understand why. So the case is important, as I said, and let's just go through some of the relevant things about this actual case. So here we have a 23-year-old male, and he has a past history of asthma, some seasonal allergies, and he came into hospital because he had a sudden cardiac arrest. He was on his way to college with his mother. She was driving him to college. Suddenly, I assume in the front seat, he spilled his drink and then became unresponsive. Mother reported he did not complain of anything before the event. They were laughing, playing around, and then suddenly stopped talking, spilled his drink, lost his breath, and became unresponsive. And this is how a sudden cardiac arrest presents. And so, what you have to take into consideration is that, thankfully, this young man survived. But he was so lucky that this occurred with someone present. If this had happened in his room on his own, or even in the bathroom, if he had been in the car by himself, that would have been possibly, most likely, a terminal event. Because when you understand what happens when you go into these cardiac arrhythmias, younger people tend to go into ventricular fibrillation. And the heart is beating so fast that it can't actually pump. And so therefore, it's like the heart has stopped beating. So there is no longer a cardiac output. No blood is going to the brain, and they collapse. And if you don't shock them out of that rhythm within a few minutes, you increase the risk of brain damage and other organ damage, as we will see in this case. So this is very, very important. And when the paramedics came along to see him, they could see that he had no pulse, no blood pressure. He was blue. That's what cyanotic means, but no history of trauma. They found he had ventricular fibrillation, just as I said. So the heart was going so fast it couldn't pump. And they started CPR. And after 7 minutes, they got, and 3 shocks, they got return of spontaneous circulation. Actually, it took 20 minutes en route to the emergency department. So they started 7 minutes after he had collapsed. So it took them 7 minutes to get onto the scene. They got spontaneous return of circulation within about 20 minutes. And they were able to manage the ventricular fibrillation with medication. So this is the presentation of sudden cardiac arrest, that ventricular fibrillation, especially in younger people. This is most likely what is likely to happen. What's important in this case is that he had a family history of a specific heart condition that could predispose to arrhythmias. So you may be thinking, well, why am I talking about COVID? Just follow along again. So just stay with me here. So, as you said, the patient's father died at 38 years due to sudden cardiac death, with autopsy findings consistent with hypertrophic cardiomyopathy. The heart muscle is big and it is predisposed to having arrhythmias. An uncle also had the same diagnosis at the age of 30. So he has a family history, but he had not had any genetic testing. And so, of course, the natural presumption in that case is to assume that because he has this family predisposition, this is the most likely reason why this occurred. Now, as I said, they got back a return of spontaneous circulation. As you can see, he had some kidney injury because he didn't have blood flow. His certain enzymes were elevated with relation to the heart. We can see his troponin went from 0.01 to 8.75, so that's a big jump. He had some damage on the ECG, and so you can see that this was pretty serious. However, luckily, he didn't have a anoxic brain injury, meaning that the oxygenation to his brain didn't do any long-term damage. And so all the blood tests, except for the urea, the creatinine in terms of his kidney function, were largely normal, and slightly elevated heart enzymes at the time were then associated with this case. So his white cell count was normal, hemoglobin was normal, his clotting was normal, troponin was normal initially, but rose in 6 hours up to 8.75. So this is standard, straightforward stuff, what we'd expect in this case. And he had some ECG changes as well. All fine. This is what you expect. Now, what then happens is the natural presumption is that this is in relation to genetic predisposition and hypertrophic cardiomyopathy. And so I'm taking you down into a part of the paper here, and then I'll come back to what I'm talking about. Here we see comprehensive genetic testing, including the cardiomyopathy panel, was negative for any known pathogenic variants. So he had no genetic predisposition. They did infectious and autoimmune workup, looked for some viruses, don't know which ones, bacterial screening, rheumatology. Everything was unremarkable except for a very mildly weakly positive anti-nuclear antibody. So in effect, they did not that he was discharged, stable, baseline mental status, only some mild procedural pain where they put in the defibrillator, and he was fine. So they put in a defibrillator because they expected that there could be an increased risk. So what we have is a case of a 23-year-old who had a sudden cardiac arrest, even though he had a family history of sudden cardiac arrest and a variant. He himself did not have any genetic link, and he did not have a hypertrophic cardiomyopathy. So why did he have a cardiac arrest? Now, this is the point that I'm coming to, is that until COVID is part of almost every differential that does not make sense, that's where I think the clinical community needs to go. If you have not got a clear answer, you should be including a question about COVID in that diagnosis. So let's look in a little bit more detail at what they found. So they then look at a cardiac MRI. Well, before the cardiac MRI, they did an echocardiogram, which shows some damage. Some parts of the heart weren't contracting properly, and the pumping of the ventricle had been reduced, which is not surprising because he had some damage to the heart from the event. They went on to do an MRI of the heart, and it showed that the ventricle was normal in size and shape, and the ejection fraction was 52%, which isn't too bad. He had very mild hypertrophy, meaning increased size to the muscle in the intraventricular septum, that's between the ventricles, but it's not significant. But here's the bit that stands out. They did a biopsy, an endomyocardial biopsy. That's where they take a little sample of heart muscle. It showed, again, mild hypertrophy, but clearly not significant, and patchy interstitial fibrosis. Now, this is extremely important. They found no evidence of active myocarditis. As I said, genetic testing was normal, but they found patchy interstitial fibrosis. Okay, this is now where we get to the serious stuff. In March of 2025, the Japanese produced a paper that was mind-blowing. It was such an important paper. They found a new heart condition. They'd never seen it before. And this is cardiac multiple microscars, an autopsy study. Now, if you haven't known, autopsies these days, they don't want to do because they're going to just keep on finding strange stuff, which they don't want to talk about. But in this case, they found 3 patients with unexplained cardiac arrest. And when they did the studies on it, they found multiple microscars in the myocardium of the 3 patients who had this cardiac arrest. This was one of the few autopsies that had been done, and it found a condition that they have never seen before. In effect, when you looked at what the authors said, they had not seen this condition before. After 30 years of pathological conferences, never seen before. This is now where you have to get back to the science. It was so important that I did a whole presentation, a whole course almost on this, because I thought that this was a critical piece of information to understand. So I'm going to show you some of the slides from that presentation. And it gives you here a picture of the heart muscle. And this is what the fibrosis can look like in the heart. And in the multiple microscars, these are bigger than what it would be because these were tiny microscars scattered all throughout the heart muscle. And this is closer to what it would look like, these tiny little dots of microscars. Now, the reason it's important is because every one of these scars can trigger an abnormal rhythm. And so in the context of people having ventricular fibrillation, this would definitely increase the possibility. And this is a normal ECG here with the ventricle contracting with the QRS complex. And what then happens, this is now an ectopic, what it would look like if one of them had fired and produced an extra beat. This is atrial fibrillation compared, but the one I want to show you is this is ventricular fibrillation. So instead of 70 beats per minute, suddenly you may be having 300 contractions. The heart is just fibrillating, it's not contracting, and this is what then caused the arrest. So this is very important. Multiple microscars. What was really strange about this paper, because I had to think to myself, I went and found this here just to show you why I think this is important. So I went looking for the paper. This is in Google Scholar. And when I looked for this paper, cardiac multiple microscars, and they spoke about it here, what you look at carefully is that it was cited 3 times since March, okay? Of the citations that were done, 2 of them were from the same Dr. McCullough, and one of them from Martinez in a book. This is probably one of the most important pathological findings in relation to heart disease that I could ever imagine. And nobody's reading it, nobody is citing it, nobody is doing follow-up research to understand what are the implications of whether or not this is occurring more often. And you know why I think that they don't want to talk about this paper? I'm going to show you what they said in their summary, because this is largely the reason that I think this is not being done. Just give me 1 second here. Okay, this is the bit that I think is the reason they don't want to show it. They want to do this. So this is likely, this is a discussion of the paper, the first report of a patient with cardiac multiple microscars who died of cardiac arrest. Okay, now 2 of the patients did not have history of COVID-19 and 1 did. Regarding COVID-19 vaccination, all 3 had histories of booster vaccinations up to the last admission. This is over 5 and 6 boosters. And they have asked the question in this paper as to whether or not there is an association between the amount of COVID vaccines and the development of these microscars. This is the point. This is very inconvenient. Nobody wants to talk about this. Nobody wants to think about this. But if this is occurring broadly across the population, the implications going down the line are horrific. And here's how you will know. And I'm saying this from a position of actually knowing that this is a problem, because I am absolutely sure that where you will find the answers are when they're doing extended monitoring of the heart. I suspect that what we will find is a significant change in the amount of abnormal beats that are occurring in people. At the moment, we don't have any clear protocols about it, but I suspect that this is only going to rise and therefore increase the risk of unusual heart rhythms over time. And this would then tie back, and if just in case you had forgotten what we were talking about, remember when I spoke about the microscarring, he did have microscarring. The endomyocardial biopsy revealed mild hypertrophy and patchy interstitial fibrosis. This means scarring, okay? Even though he had no active myocarditis, he may have had myocarditis with patchy interstitial fibrosis. It doesn't seem that COVID vaccination status is included as standard in these papers, but I can extrapolate. He's 23. his college, the majority of colleges in the US had vaccine mandates, and the COVID was circulating. He could have either had infection or post-vaccination myocarditis, or a combination of both, with multiple microscars, which could put him at risk for arrhythmias. But he's one of the lucky ones, because now he has an internal and implantable defibrillator device. So if that was to happen again, he would get a quick shock and he's back to normal. For other people, you just have to hope that if something like that happens, you are in a position where you can be identified and treated as quickly as possible. He was very, very lucky. And so if we continue down this road of ignoring pathology, because that's the only thing I can say, it's ignoring the pathology of multiple microscars never been seen before. We have no idea if this is broadly occurring across the population. But again, I can extrapolate that based on this specific case, who had patchy interstitial fibrosis, he has microscarring as well. How many other people? How long will it have to wait before there is a change that allows clinical medicine to start leading from the front and stop pandering to the political narratives that are more protective for politics and industry? Clinicians have a duty for patients, not for systems. Fundamentally, that's where our oath takes us, to protect the patients. And if this is happening, we have to find out. We cannot afford to not know if this is not a risk. How we identify it, I don't know yet. That's where our best cardiology minds will come in. But the only thing that I can do now is raise the awareness. More questions need to be asked. More challenge needs to occur if we are ever going to have any chance to risk mitigate. Because as I said, if we know, we can do something about it. If we don't, the outcomes, similar to what happened with smoking in the 60s and the 70s, we can predict where it's going to go. It may take 5 years, 10 years, but at some point, the science is going to catch up. Thank you for listening.
A hero, an immune adventure. Humming Heroes, your lyrical guide to the body's defenders. Now on Amazon. Check the links below.